Germinal matrix hemorrhage. Before we start, we have five main questions. What is the germinal matrix? What's its importance? Where is it located? It is transient or permanent? And why germinal matrix hemorrhage is the commonest intracranial hemorrhage in neonates? I will give a short brief about cranial ultrasound. First, I will talk about indication and advantage, timing of full ultrasound, techniques and anatomy, and two main pathology, as I said, germinal matrix hemorrhage and PVL. First, what is the indication for ultrasound? First, to exclude germinal matrix hemorrhage, especially in preterm, and exclude hypoxic ischemic encephalopathy, especially in neonates near full term. Exclude any brain anomalies and any sick neonate who suspected to have brain pathology to assess timing and assess the prognosis. And finally, to exclude congenital or acquired brain infection. What is the advantage of the ultrasound? It is safe, bedside, reliable, inexpensive, and the best advantage, it allows early and serial imaging. Timing of the ultrasound, we have screening program, two screening program for high risk neonate and for low risk. We will start from high risk, neonates who are in ICU or less than 1,500 gram or less than 32 weeks. We will start from day 0, less than 24 hours, and on the third day and on the seventh day. This is the first week. Then twice until the second week. After that, we have to follow weekly until discharge or full term. Neonates on special care unit who are low risk, more than 32 weeks, or more than 1,500 gram, we will start from the third day, then weekly until discharge. Ultrasound may be frequently repeated in cases of suspected abnormalities depending on the clinical picture. What is the importance of this screening program? First, the first clear ultrasound serves as a baseline and a comparison for the next ultrasound. And each one of us have to know hemorrhagic lesions visible within hours of the incident. And most hemorrhagic lesions develop around the birth. 90% of germinal matrix hemorrhage develop within the first 3 days and may progress within 3 to 5 days. So this screening program allows detection and extension of the hemorrhage. Second, it enables detection of acute stage of hypoxic ischemic encephalopathy. So both topics are covered, hypoxia and hemorrhage. Techniques and anatomy. As we know, ultrasound waves don't like gas or bone, so we have 4 acoustic windows. Anterior fontanelle, posterior fontanelle, mastoid foramen, and temporal window. We will start from the standard views. We have 6, at least we have to get 6 coronal planes, starting from passing from the frontal horn till the occipital horn, passing through the anterior horn of the lateral ventricle, then through the third ventricle, then at the body of the lateral ventricle, then the trigone, and last the occipital horn. We have also to gift at least 5 coronal planes, mid sagittal plane. This is corpus callosum, mesa intermedia. This is the vermis, and the 2 median parasagittal passing through the caudate and thalamus, and this is the choroplexus, and 2 lateral parasagittal plane reaching to the sylvian fissure and the assessment of the white matter. We can assess through the mastoid formations. We can assess the posterior fossa well and assess the cerebellum. This is the vermis, and this is the fourth ventricle. This is the sternum. Pathology, we have germinal matrix hemorrhage, PVL, congenital malformation, brain infection, intracranial hemorrhage. We will start from germinal matrix hemorrhage. Before we start, we have 5 main questions. What is the germinal matrix? What is its importance? Where is it located? It is transient or permanent? And why germinal matrix hemorrhage is the commonest intracranial hemorrhage. What is the germinal matrix? It is a fragile thin-walled vessels and migrating neuronal components. It is formed early during embryogenesis, and it is the site of glial and neuronal differentiation from which the cells migrate peripherally to form the brain. And it is transient, involute by 34 weeks, and start progression from 24 weeks. After that, the remnants remain in the thalamocaudate notch and in the temporal horns. Where is it located? It is located within the periventricular region and in the ganglionic eminence, and most pronounced in the caudate nucleus. This is the ganglionic eminence, and this is the caudate nucleus. This is the caudate nucleus. Okay. Why it is the most common intracranial hemorrhage in neonates? Because it is highly vascular, highly metabolic, and highly cellular. So any affection on any hypoxia or ischemia will cause hemorrhage. And it is highly vascular. This vasculature is fragile because the blood-brain barrier, as the germinal matrix, is distinct because due to lack of pericytes, which lack of coverage. This is the pericyte, and lack of fibronectin within the basal lamina of the basement membrane, and the lack of glial fibrillary acidic protein, which is secreted from the astrocyte in the feet. This is the astrocyte in the feet. This is the pericyte. This is the basement membrane. So it is fragile. So any neonatal stress, any perinatal stress, plus poor cerebral tribulation equal hemorrhage. What is the risk factors? We have two intrinsic factors, low birth weight and cyanotic congenital heart disease, and two extrinsic factors, prolonged labor and multifetal pregnancy. As we said, any perinatal stress plus poor cerebral autoregulation equal hemorrhage. Let's start. Germinal matrix hemorrhage, known as periventricular intraventricular hemorrhage, and it is the commonest type of intracranial hemorrhage in neonates, and usually occur within the first week of life, and may cause significant morbidity and mortality in this population. 90% of germinal matrix hemorrhage are identified within 4 days of birth, and 40% within the first 5 hours. The more the prematurity, the more the hemorrhage. 80% of infants born between 23 and 24 weeks develop germinal matrix hemorrhage, and 67% of infants born between 28 to 32 develop germinal matrix hemorrhage. Clinical presentation, grade 1 and grade 2, usually asymptomatic and found on routine ultrasound. Grade 3 and grade 4 usually come with respiratory stress, abnormal posturing, seizure, and maybe bulging of the fontanelles. Grade of the germinal matrix, we have 4 grades, grade 1, grade 2, grade 3, grade 4. We will start from grade 1. It is limited to subependymal region within the caudothalamic group, overall good prognosis and 3.1 mortality. This is the normal, this is the caudate nucleus, this is the thalamus, and this is the coronal plexus. You can find echogenic lesion anterior to the caudothalamic group, and we have bilateral grade 1 germinal matrix hemorrhage. Grade 2, it extends into the normal sized ventricles, filling less than 50% of the volume of the ventricles, overall good prognosis, and 7.8 mortality. This is the hemorrhage. This is the hemorrhage extend into the normal sized ventricles. Grade 3, extensive hemorrhage with ventricular dilatation, and 21.3 mortality. This marked ventricular dilatation with hemorrhage. This is the hemorrhage. Okay, grade 4, any parenchymal involvement in the previously mentioned 3 grades, it is called grade 4, and it is caused due to conversion of the outflow of the veins by the subependymal hemorrhage. And it's called the periventricular hemorrhagic infarction. Any parenchymal involvement is called the periventricular hemorrhagic infarction. This is periventricular hemorrhagic infarction, and this is the frontal horn. It's completely filled by blood. We have grade 4 on the left side and grade 2 on the right side. By CT, in hyperdense region, keeping with hemorrhage. And in grade 4, we may have found low density areas which represent venous infarction and hyperdense areas which represent hemorrhage. This is a case of marked CT brain, non-contrast CT brain. We have periventricular hemorrhage and the marked dilatation of the ventricular system, and we have CSF blood level. So we have grade 3 germinal matrix hemorrhage. By MRI, it depends on the age of the bleed, maybe hyperacute, acute, early subacute, maybe late or chronic. Here we have a case of marked dilatation of the ventricular system, and we have altered MRI signal seen within the lateral ventricle, extending to the coronal plexus, displaying bright signal fill T1, and low intensity REM fill T2, and high signal fill flare with restricted diffusion. So we have grade 3 germinal matrix hemorrhage with early subacute blood. Complication of germinal matrix hemorrhage, post-hemorrhagic hydrocephalus, periventricular leukomalacia, cyst formation. First, post-hemorrhagic hydrocephalus, periventricular leukomalacia, subependymal germinolytic cyst, and unilateral polycephalic cyst. What is the treatment? The ideal treatment is the prevention of premature delivery. If it is a must, you have to give dexamethasone for the mother or indomethacin to the infant, and you have to treat the complication. If there is hydrocephalus, you have to do CSF drainage. The second main topic is periventricular leukemia, hypoxic ischemic encephalopathy. Before we start, I will give a short brief about neonatal hypoxic ischemic brain injury in infants, depending on the severity and timing. If hypoxia occur before 28, we may develop hydranencephaly and oranencephaly. If between 28 to 32 weeks, likely it will present with germinal matrix hemorrhage. Between 32 to 30 weeks, if it is partial, it will affect the watershed areas, which is the periventricular area in this age. It will present with PVL. If profound hypoxia, it will affect the thalami with cerebellum and the brainstem, and will spare the basal ganglia and the cortex due to later myelination. If full term, if it's partial, it will affect the watershed areas. If it is acute profound asphyxia, it will affect the basal ganglia and thalami, and also it will affect the cerebral cortex, precentral and post-central gyri. PVL, it is a white matter injury of prematurity affecting periventricular zones, watershed areas. Etiology ischemia was thought to be the single cause, but infection and vasculitis may play an additional role. Clinical presentation. 50% of setting of cystic PVL develop cerebral palsy, intellectual disability, or visual disturbance. Pathogenesis, hypoxia, will impair perfusion and will affect the watershed areas which are located in a periventricular location in this premature infant, and will cause white matter necrosis and then develop cyst formation, later parenchymal loss and enlargement of the ventricles. Grading of PVL. First, PVL presents as areas of increased periventricular echogenicity. And we have grade cystic and non-cystic. Non-cystic, which is grade 1 and persistent more than 7 days. Cranial ultrasound may be normal in patients who go on to develop PVL. And so we have a good protocol is ultrasound examination weekly until discharge all 4 terms, as we said before in the screening program. We will start from grade 1. Increases periventricular echogenicity more than 7 days. It is asymmetric. This is larger. This is smaller. Inhomogeneous, coarse, globular, and may be more hyperechoic, may hyperechoic than the coronary plexus. Grade 2 يحصل small periventricular cyst, and the echogenicity has resolved at the time of cyst formation. If cystic PVL on the first day, it is impressive of at least 2 weeks prenatal hypoxic ischemic insult. Grade 3, extensive cysts in the frontal and parietal and occipital lobes. If this cyst reaching to the subcortical areas, it is grade 4. When we talk about PVL, we have to mention flaring. What is flaring? It is the periventricular echogenicity that's seen in the many premature infantis in the first week of life. Is it normal or sign of PVL? First, if flaring persisting more than 7 days, it's considered PVL grade 1. How to differentiate between physiological flaring and PVL? Physiological flaring, echogenicity is bilateral and symmetric, and it's subtle, it is homogeneous. But in PVL grade 1, it is coarse echogenicity, asymmetry, and inhomogeneous globular, and more hyperechoic than the coronary plexus. This is a case of 26 born newborn. We can see bilateral increased periventricular echogenicity. After 14 days, partially cystic formation developed. After 8 weeks, the cysts became more obvious. And this is the MR of 6 week bilateral periventricular cystic changes. What is the differential diagnosis? First, subependymal cyst, germinolytic cyst, post-germinal matrix hemorrhage. Congenital cyst, it is present superior lateral they are present at the superior lateral aspect of the frontal horn and choroid plexus, and bronchocephalic cysts communicate with the ventricles and follow luekomalacia. Take home message. First, you have to follow the hygiene protocol before any ultrasound procedure to the neonates. Second, when you are doing ultrasound for preterm, you have to suspect first germinal matrix hemorrhage. If neonate with near full term, you have to suspect PVL. And remember the screening protocol 037 on the first week, twice on the second week, and weekly until discharge. This is for high risk. Germinal matrix hemorrhage and PVL are serious conditions that may develop cerebral palsy, intellectual impairment, so don't miss. You have to remember feeding is bilateral, symmetrical, homogeneous, and not persisting more than 7 days. And it is a physiological. Thank you.